Welcome, and thank you for joining this CanCOVID talk on preventing and reducing homelessness during COVID-19. My name is Kevin Pottie, and I am a professor in the departments of family medicine and clinical epidemiology and community medicine at the University of Ottawa and at the Bruyere Research Institute. Homelessness, this is something from The Guardian in 2021, showing that 70,000 people have found themselves homeless because of the pandemic, and this is just in the UK. As we reflect a little bit on the COVID epidemic, we realize that it's had a massive impact on people losing employment, and we know that loss of employment can lead to loss of income, and this can lead to loss of housing. This is something that's barely being monitored right now as we're all struggling to get through the pandemic. And so I think that's what this talk really is about, is just reminding people that there is often so far unseen and something events that are happening regarding people falling homeless during COVID. So the people that are currently living homeless are reporting feeling very forgotten and abandoned. They're often sick and alone, struggling again how to get through the winter. A lot of resources have become restricted due to COVID restrictions. On the positive side, there's been a number of field innovations that we see in the UK, Canada, and the US, reorganizing shelters where we have certain shelters being used just for COVID isolation and care, taking advantage of the empty hotels in many of the major cities in New York and London, and using those to shelter people that don't have homes. Finding innovative ways to test and people that are sheltered or unsheltered. Sometimes it's hard to find people that don't have housing as well. And one of the positive things was recognizing that they are at the highest risk for the virus and for complications from the virus, and seeking to have early vaccination programs of homeless populations. So I think these are some really positive elements that have come during the epidemic. At the same time, I feel we're launching a series of evidence-led movements to end homelessness. It's not easy to launch such things during the COVID pandemic, but I feel like in Canada, we have launched the Homeless Health Research Network with Tim Albury and myself. In the UK, Lygia Tejeda is leading the homelessnessimpact.com network. There's the Housing First Pathways network that Sam Barris has launched in the US. And in Europe, there's Jeff Nelson's Europe's Housing First Hub. So I think that these networks link to, for instance, some of our recent papers in the Lancet and our guidelines in the CMAJ, as well as having this move into the Dynamed app and other resources for clinicians, is finally helping people to bring evidence-based approaches to the treatment of homeless people. Our initiative was a evidence-based clinical guideline that we published in 2020. It actually came out in the media on the actual day that WHO announced the COVID-19 as a pandemic. We went from 45 booked interviews to introduce our guidelines beginning at 4 in the morning. And unfortunately, by about 5:10, we had been pulled and COVID took over the airways. And so our guidelines were quietly entered into the public literature, and we're looking forward to getting this out over time. This slide shows at least some of the members, at least on one of our 15 papers. And I think what I was really proud of is that we have 25 people under 25 as leaders and authors on our projects. And this is, to me, the future of this evidence-based homeless health. And something else that was unique was that we hired and worked for 3 years with people that had lived experience of homelessness, and they worked with us on the systematic reviews and the guidelines, and were our daily almost advisors on understanding the perspectives of people living homeless. And homelessness is often described as an extreme form of poverty characterized by the instability of housing and the inadequacy of income and health care supports and social supports. And this is prior to the pandemic. We talked about estimated numbers of around up to 300,000 people, Canadians experiencing homelessness each year. And we recognize that the rates of chronic illnesses and acute illnesses are much higher, to the point that for a chronic homeless person, the life expectancy for men is reduced um, significantly to the age, and for women as well. Our method included reaching out to 150 people across Canada. That included 75 people with lived experience of homelessness in shelters and food banks, and asking them, plus 75 clinicians, what were the real needs, the health needs that we need to do to prevent and to do something about homelessness. From that Delphi consensus and a Montreal summit, we were able to do 7 systematic reviews. And then from these systematic reviews, which are all published separately, we developed our evidence-based grade guidelines. And we continue to translate these into checklists and different tools for clinicians and for policymakers. Just to give you a glimpse of one of the things that is coming out of our initiative is something called the house prevention approach. This is something that we're trying to bring for emergency room and primary care clinicians, so that they are actually aware and ready to look for housing precarity, think about the outcomes of mental illness when they're seeing somebody in the emergency department, understanding the importance of income and the fact that income is often available for a lot of people, but just they haven't necessarily completed the correct paperwork. And then understanding the importance of some type of case management for mental health. And finally, the awareness around substance use. So this is called the house prevention approach, which also appears in our Dynamed chapter for clinicians. This slide doesn't want to advance. Okay, so just to give you a more detailed glimpse of what our actual evidence-based recommendations were, after all the Delphi and going from issues such as diabetes, tuberculosis, HIV, and having those on our list, but those falling down away from the top 5, we realized that the thing that must be done for healthcare of homeless people is to recognize someone that's experiencing unstable housing, and to use resources that are currently already in a lot of communities, excuse me, and already developing in many others, to help people find housing at the moment when they're starting to lose their housing, and before they fall into the potential culture and the challenges that are awaiting somebody that is having to live rough or on the street or in the shelters. So this is by far the most important recommendation, and we believe it's going to take an awareness of all healthcare providers as other allied health persons to be aware, and for us to develop programs. And this one we recommend as a strong recommendation, which we believe we're able to show moderate certainty evidence, meaning that this is a very secure finding that really needs to be addressed, just like we give lytic agents to people that are having chest pain and heart attacks. So it's a very similar strong recommendation that if we want people to live, that we're going to need to make sure that this housing is looked after first. This is just a quick glimpse of our meta-analysis published in the Lancet Public Health that shows the significant findings with people living for up to 6 years in these once they've been housed. And this is a huge success. A lot of these studies were led in Canada in several different settings, and these studies have been done in the UK, Canada, and in the US. And so there's a lot of evidence now and consensus that finding stable housing is where it's at. We also did look for other signs of their outcomes, and we actually, in our systematic reviews, were not able to document clear benefits for issues such as mental health, substance use, employment, and income directly. And we found mixed findings around outcomes for quality of life and hospitalization. We recognize that to some extent this could be related to the heterogeneous nature of the actual program or the length of time that some people have already spent living homeless. So these are issues that need more research, but the idea that the intervention works is clear. The second recommendation focuses in on on income insecurity and the fact that it is quite easy for someone to detect income insecurity when they're seeing a person. And when this occurs, we need to be moving them into a program where they are offered help in terms of filling out forms. Often income insecurity is what can block them from getting housing. And so sometimes this is just a really important initiative that we want everyone to be on the lookout for. The third recommendation focuses in on the fact that many people that are living homeless or falling homeless are suffering mental illness, sometimes severe mental illness, and they often will benefit from special programs that have been developed that are called assertive community treatment, critical time interventions, and intensive case management. These have been extensively studied, and again, we found evidence that showed that when people have had access to a program, their health will do better. The findings around case management and the different forms of case management are fairly complex, and in this table we're just showing that there's still there's no question that there's a lot of complexity with chronic diseases and other challenges that happen depending on how long someone is homeless and what particular comorbidities they face. However, there's definitely signs you see on the left side that these programs are working to ensure housing stability and also working to improve issues such as substance use and hospitalization and quality of life. The fourth recommendation focuses on addictions and recognizing that we now have successful programs to help people that have opioid substance use. These opioid agonist therapy programs are now existing across Canada. These can be started by any family physician or nurse practitioner. And these are very successful programs that help bring people into the healthcare system and help people find jobs again and kind of help to transition back into regular life. There's certainly been a lot of stigma around addiction and homelessness, but there's also been a lot of successes. And I guess a few of our members of our team had the positive impacts of these programs, and I had opportunity to see this one-on-one over 3 years, and it's very remarkable to see people returning to useful employment and really contributing to society. The final element is focuses again around problematic substance use and alcohol use and the value of supervised injection facilities. We found clear evidence that supervised injection facilities prevent death, prevent HIV, as well as they also link people to healthcare services. And so it's something that has met some concerns with politics and societal values, but the evidence was very clear, and we found evidence that homeless people will benefit just as much as anybody else from these special programs. So we published this systematic review in PLOS One. So going to continue through, and I'll show at the end where all of our studies can be found. Just really want to focus on the idea that a homeless person is not your middle-aged or older man that has maybe found trouble with addiction and lost their job, but rather it's a very diverse group of people. And so when we care for it, we develop programs for, and we have to be aware when people are unstable with their housing, we must be totally thinking about issues around gender and sexual orientation, age, Indigenous links, which is something really important. There's a very large disparate number of people with Indigenous roots that find themselves homeless. Issues as well with race and ethnicity, trauma history, and employment and housing, of course. The practitioners, we want them to be aware that primary care continuity may be one of the most important missing links that currently exist. When we have a housing first program, we're integrating people into their apartments and housing, and we're integrating them with sometimes outreach mental health teams. The final piece that seems to be very slow for pickup is having them entered into our interdisciplinary primary care teams. This is something we saw throughout the whole project. There are some exceptions, but we definitely need more awareness and more ability for the teams around Canada to be able to help reintegrate people that have been homeless and often fallen away from the full healthcare system. And there's a lot of benefits to being part of the full healthcare system versus just a kind of a walk-in clinic or even a clinic associated to a shelter. What we're interested in is that these people are getting the full services, and that's very important. So just a reminder that COVID-19 has had amplified inequities, created sometimes havoc with homeless people and homeless shelters. And we continue to, although there's been vaccination, we're still watching very closely for outbreaks, and there has been a number of outbreaks earlier on in the epidemic. We believe we're now building a manual for medical students called the House Approach to bring community service learning to medical schools so that young medical students and physicians will have the house approach, just like the ATLS cardiac approach, to be able to identify and act when they recognize someone with unstable housing to prevent the very substantive mortality and morbidity that can come when someone actually falls homeless. This final slide just highlights our website, which is at the Cochrane Equity Homeless Guidelines, part of our Cochrane Equity Methods website. We have here a whole collection of the 15 papers, including a curriculum for undergraduate students, 7 systematic reviews, 5 other reviews on populations. And yeah, we like to think that this is going to be a substantive research base, which will lead to focus and ongoing research to improve the outcomes from both preventing homelessness as well as when someone has homeless to help them get back and transition back into society. Thank you very much. I'll stop here to see if there's any questions.
Thank you, Dr. Pottie, for such an interesting and informative presentation. We do actually have a couple of questions. So the first is, what are the best things we can do to prepare for future pandemics with regards to homelessness?
Well, of course, there's been some real success stories. I have to mention Finland, as well as a few towns in Western Canada that have virtually eliminated chronic homelessness. And they're able to act quickly to house people. And this is a much better use of resources than to try to transition somebody that has been homeless for many years back into society. So from our housing first concept, and we really want to get ahead of the game in terms of having the least number of people homeless when the next pandemic hits, because we know that this is the group that will face the frontline risks, as well as brings a lot of challenges with isolation and a lot of suffering.
Thank you. And the next question is, how is this research being advanced to help make a stronger case for a national housing strategy?
Well, Canada is advancing a level of a national housing strategy, but I believe there's still a disconnect between the housing and the health ministries. I believe we actually need some initiative in the federal politics that would bring together the housing and the health, because I would believe when you transition back into housing and into the community, you need to also transition back into the health system. And right now we have a really disconnect in this group. This is probably the final piece that I'm most disappointed we've not been able to impact, despite many letters to the Prime Minister and to ministers. that we recognize that we need to be training our medical students and our social workers and our housing workers together, because there is a real disconnect in terms of integrating, transitioning people back into the actual health system. So although we're succeeding in getting people into housing, I don't believe we're succeeding in getting them into our full service interdisciplinary primary care centers. And this is a place that really, I think we can provide really high quality care and help to enable a very successful long-term transition.
Great. Well, thank you so much for taking the time to present today. And the House Initiative and the incorporation of medical students and students in training to help expand that and its principles is a great idea. And so best of luck with that initiative.
Yeah, thank you so much for having me, and I look forward to maybe doing this talk in a couple of years when we have a retrospective of what COVID has actually caused in our communities, because we're really not able to keep up with statistics and homelessness right now.